Request Dr. Bharath Kadadi sir to come on stage, take us through the clinical examination of brachial plexus injury. Mr. Adarsh, I request kindly to come on stage.
How many are postgraduates here? Still standing, last man. How many are wanting to take DNB exams? Nobody. So everybody is a consultant. Why? One guy. Good day. Nice to have you here, sir. I am sure this presentation will be beneficial to you, as well as to the young practicing surgeons. Dr. Bharath has done great work on brachial plexus. We have seen him grow over the years, and I am sure he will add value to this presentation. Yep.
Absolutely, sir. The kind of work he does is really niche work. Dr. Bharath Kadadi, so it is really a pleasure to invite you, sir, for the program. And all of us should know that it is just operating on the shoulders might be pretty easy, but handling complication, including nerve injuries, is a great deal. So I myself have had nerve injuries. So he has helped me with the nerve injuries of mine. So how to assess is very important. So let's hear from him. Thank you, sir.
Thank you, Dr. Ayyappan, for the sweet introduction. At the outset, I thank Dr. Ayyappan and the team for the very wonderful Bangalore Shoulder Summit. Dear chairpersons and colleagues. So my presentation will be 5 minutes on the PowerPoint, and then 5 minutes will examine my friend Adarsh. So way back, 20 years back, I published this work on that clinical examination is very important. Only when clinical examination is combined with nerve conduction and MRI, then will give you a better predictability in predicting the site of lesion. So that shows how important is a clinical examination. So not to confuse you all, just to recap, don't get panicky that you have to examine all these muscles and then how do you go about it. There is a simpler way of doing it. So let's look at the myotomal distribution. Just C5 means shoulder abduction external, C6 is for elbow flexion, C7 is for elbow, wrist and finger extension, C8 is for wrist and finger flexion, and T1 is for intrinsic function as diagrammatically represented here. The C5 for the shoulder, abduction external, C6 for the elbow flexion, C7 for elbow extension, wrist extension, finger extension, C8, T1 for the finger flexion. Once you know this, after examination, you can approximately place where is the injury in the patient, and 70 to 80% of the time, you'll be able to locate the site of the lesion. Often these are high velocity injuries, and the injuries can cause either a rupture of the roots, cords, trunks, or it could be a avulsion, as you can see here. So it's very important to differentiate between avulsion and ruptures, because ruptures can be repaired, avulsions cannot be repaired. So here comes, so you must be able to differentiate whether it's a preganglionic injury before the ganglion, dorsal root ganglion, or post-ganglionic injury, where the injury takes place at the root level or the cord level or the trunk level. So it's important to differentiate. So some of the telltale signs I would like to all of you to observe. Look at his left eyes. There is ptosis, meiosis, and that's what is Horner syndrome. It's often a result of C8T1 avulsion. Next, you have the winging of the medial butt of the scapula because of loss of serratus anterior, which supplied by 5, 6, 7 root level, the long thoracic nerve, and that's how winging of scapula looks like. Prominence of the medial border. If you ask a patient to push the wall, the prominence of the medial border because this serratus anterior is not working. So winging of the lateral scapula, that means whenever there is a rhomboids not working, as you can see in this patient. If you can compare to the opposite side, the turgor of the muscle, the tone of the muscle is gone. So when you know that it is one of the proximal muscles affected, that it could be more likely to be a preganglionic lesion. Absence of tinel sign will come to it, and normal histamine test. When you put in a drop of histamine, the triple response, the wheal flare and redness will be intact in a preganglionic because the axonal response is intact. Whereas in a postganglionic, because the axonal response is gone, they will not have the triple response. Important to say that associated injuries are very important. It's a part of the examination of brachial plexus. You must keep in mind vascular injury, ipsilateral upper expiratory fractures, scapulothoracic dissociation, rib fractures, pneumothorax, hemothorax, lung contusion, spine injury, spinal cord injury, and traumatic brain injury, because this alters your management pattern, and then you know when to intervene, when not to intervene, how long you have to wait. All this is very important to remember in mind. Now the commonest pattern, one of the commonest pattern of presentation is 15% is the upper type. In a high velocity injury, supraclavicular, rotary aortic, close traction injury, 15% is upper type. 25 to 30% is 5, 6, 7 extended upper type. This is called extended upper type. Only 5, 6 is upper type. This is 5, 6, 7 is extended upper type. And let us see how the patients with the extended upper type present. The 5, 6, 7. You'll be able to appreciate the sulcus sign there. Subluxation of the shoulder because the shoulder is flail. And you must examine the trapezius by shrugging of the shoulder. And you can see there's no active movement of the shoulder, no abduction, externalization of the shoulder, and there is no active elbow flexion also, except that you see there is some wrist finger flexion. Wrist flexion and finger flexion are present. It's very important to look at the pulse, feel the pulse, and then if you look at the patient, there is no finger wrist extension, more pointing towards that it could be a involvement of 5, 6 and 7, whereas C8 and T1 finger flexion is intact. This is a second commonest pattern of presentation. And look at the wasting, supraspinatus, infraspinatus, and also the rhomboids. The third pattern of presentation, which is very common in high velocity injuries affecting the youth of the country, is 55 to 70% where you have involvement of all the roots. Remember, whenever there is a preganglion, some roots could be preganglionic injury, some roots could be postganglionic. There could be a rupture of 5, 6, 7 and avulsion of C8, T1, or a rupture. There could be a combination of patterns which can be confirmed with your exploration and of course with your MRI scan. So this is how the pattern of a total palsy presents. It's a flail upper limb. You can see the Horner syndrome. Look at the shrugging of the shoulder. Trapezius is very important because you often use donor trapezius. That is a spinal axillary nerve as a donor. So important to make sure the trapezius is intact. Always make sure your opposite limb is fine, because many times you might have to take the contralateral C7 for nerve transfers when there is no donors. We are looking at donors, no donors. Whenever there is avulsion or involvement of the root, there is no donors. So we are looking at donors. Very important to mobilize, examine these patients in a total flail palsy. As you can see that wasting of the infraspinatus, completely flail upper limb, and you can see the hand function there, completely flail. Look at the pulse, make sure vascularity is good. Often they can have a subclavian artery injury with a poor vascularity in the limb. You cannot do some aggressive procedures like a free functional muscle transfer, so it's important. And then look at the Tinel sign. And also the supraclavicular tenderness in most of the patients gives a clue that there could be an injury at the supraclavicular region. In addition to this, you must also keep in mind that there can be a whole set of infraclavicular injuries, patterns which I'm going to discuss when you see the patient. This is a nice way of putting it in a chart, de-orbiting chart, where you mention the motor power in each of these muscles there, and you can see the overlap 5, 6, 7, and each of the muscles, the overlap of the root level. So this will approximately give you a clue of examination, diagnosis of where exactly it's involved. So here we have my friend Adarsh in question. We'll examine him in this pattern. Let's make it simple. Look, feel, move, neurological examination. Once you've done that, it's done. So Adarsh, come, can you just stand here? So what I'll do is just start off proximal to distal. Okay, you need a pattern. Look, feel, as you can see, look, feel, move, neurological, motor and sensory. Others just do the trapezius. I'm looking at the trapezius, shrugging of the shoulder, and also I would like to check the, relax, do that again. I want to see the power of the trapezius because it's a very important donor muscle. So you must document that. And then look at the sulcus sign. There's already sulcus because in an injury like this, whenever there is none of the shoulder muscles are working, so invariably the shoulder subluxates because of the weight of the arm. So that's the sulcus sign what we will be able to observe here. Just then, in addition to that, look at the waist. Turn that side. Turn that side. Yeah. Look at the wasting here. Supraspinatus wasting, infraspinatus wasting. Able to observe. You have to come on this side. Yeah. Wasting, observed, and Brachial. Yeah. Do this. Yeah. Relax. Also feel the rhomboids. You can see the tone from both the sides. There is a difference on the in the tone of the rhomboids. Turn this side again. And in a flail shoulder, it's not possible, difficult, and in a shoulder and elbow not working, it's not possible to, tell the patient to push against the arm. So how do you check serratus anterior? You just ask them to swing forward, swing the upper limb forward. That's the way to check your serratus anterior in a brachial plexus injury. Unlike in isolated serratus anterior paralysis, you can ask the patient to push the wall, but here it's not like that. You need to ask them to swing forward. Do that. Swing forward. And you can also give some resistance on that, so that will give you a clue, but it's flail. He's not able to swing forwards, or even when the patient is lying down, you can ask him to place the hand on the chest. That's serratus anterior, so he's not able to do that. And then, once you've done the active movement of the shoulder, always important to check the passive movements also. And then check the elbow. Try and ask him to flex. Once we've done the inspection, we are doing the feel now. Right? See, he's not able to flex the elbow. So, and when you eliminate the gravity, you can do both flexion and extension. You're eliminating gravity here. Hold the forearm in supination. Ask him to flex. Flex the elbow. So he's not able to do that. So elbow flexion is not working. What about extension push? So elbow extension is around 2 by 5. See, he's able to do that, but if you do it against gravity, he's not able with difficulty. See, the elbow extension push is 2 by 5. But when you do against gravity, he'll not able to do that. So it's 2 plus by 5, elbow extension. That means there is involvement of the C7 also. And look at his active supination pronation, and then come to your wrist extension. He's got a good wrist extension. He's got a good finger extension. You'll be able to observe all that. That's the radial nerve. And he'll be able to make a fist. So it's very important to examine the peripheral nerve system. And once you do the median radial ulnar nerve, then you got a picture of what is involved. Suppose the radial nerve is involved, then the posterior cord could be involved below the clavicle, and a combination of lateral cord, median nerve, and median nerve and the ulnar nerve, then the medial cord, or the combination of musculocutaneous and median nerve, it could be the lateral cord. Just a couple of minutes more. So for the median nerve, just ask them to do FPL function, FPL. See that he's able to do that. That means the high median is intact. Just ask him to do alternate clasping test, just clasp it. See, if the median nerve is not intact, then the finger pointing is called pointing finger test. Finger will point out, but he's able to flex. That means the FDP of the index is working. So once you know that high median is working, and just ask them to oppose, that's low median is working. That means opposition. And for the ulnar nerve, just ask him to do the ulnar adduction abduction. So this shows the ulnar nerve is good, and you can also do the Froment sign where you book test, where you give a book inside the hand and ask him to hold it and push, so that if the FPL flexes, if he holds with the FPL, then ulnar nerve is not working, but if he holds with the adductor, then it means that the Froment sign is negative. And in addition to that, just ask him to bring all the fingers together. That means see that MCP flexion, IP straight, ulnar nerve is working. So here in this patient, the median is working, ulnar nerve is working, radial nerve is working, the nerves distal to the elbow are all functioning well. Only the shoulder abduction externalization is weak, elbow extension is weak, elbow flexion is weak. So basically, and also you already seen the pulse. And Tinel sign, if you see, that's a part of your neurological examination. It's more of a prognostic value, just to see the advanced Tinel sign shows, suppose you've done a repair. Advanced Tinel sign will show you how fast the nerve is progressing. When you can predict on your recovery, every 2 months, 3 months, you know where is the Tinel sign. So you, along the course of the nerve, you percuss distal to proximal. So he will complain of maximum amount of tingling numbness. So that's the area when you can say that now is progressing. Sit down. And then comes your sensory examination. So the myotome which I'm going to show you, you should also do the touch and the pain sensation, both, all the two. So once you've done you looked at all this, and as I told you, passive movements also is important, because that's the whole idea of physiotherapy. If you mobilize the patient, keep the joint supple, and then you can get good results out of the repair. If the joints are stiff, you cannot get a good outcome out of the repair. So keep the joints supple, and that's very, very important part of your rehabilitation. You diagnose all the pre, post ganglionic, and also the peripheral nerves. Sensory examination, you have the sensory term, the C5 outer aspect of shoulder, C6. And then the middle finger is C7, and C8 even is the inner aspect of the forearm, inner aspect of the arm is T1. So that's how you know the sensory, and you can document that on your D-Aubin chart. So in this patient, the diagnosis is, just the last slide, 6 weeks old, that's how you put in a diagnosis, 6 weeks old, C5, C6, 7 injury, could be preganglionic, intact vascularity with deformity and stiffness of the shoulder. So this patient, polytrauma, he had a fracture of the scapula treated conservatively. He had a fracture of the left femur which was done, nailing was done. November accident, January we already operated this patient. So we have done what you call a the quadruple nerve transfer for the spinal axis to suprascapular, the triceps branch to the axillary nerve for shoulder abduction, and the double oblique, where median nerve fascicle to the brachialis and the ulnar nerve fascicle to the femur down the line. So you can expect recovery to start in 6 months. The last slide. So remember that 90% of the diagnosis is clinical. The investigations, X-ray, MRI, CT, electronics are only supportive for you. And remember pseudoparalysis. Many of the patients having fractures, they will not be able to move. Don't mistake them for nerve injuries. At the same time, avoid blunders like missing brachial plexus injuries. This can happen if you do not maintain the pattern of examination in the methodical way. You can miss out a brachial plexus injury in a polytrauma patient. Remember that, because man's greatest blunder has been in trying to make peace with the skies instead of making peace with the neighbors. Thank you, one and all.
Thank you so much, sir. It is a really wonderful session. I think this is something which we have to still learn, and also the management. I think we should have more courses and maybe classes, especially part of the BOS. I think we should take it forward, sir. Rajkumar sir, I would request Hemanade sir to, I think, take it forward. Thank you so much, sir. Thank you so much.
Thank you.
Thank you, brother.
Thank you. Thank you, others.
Thank you, Bharath sir, and thank you, Adarsh. Next, I invite Dr. Ashok Sham sir for his talk.
So, thanks Dr. Ayyappan and the entire BSS team for inviting me. So, my talk today is on reference management software. So, it's a software for recording and utilizing citations. So, I'll go through in brief about these references and softwares. So, these are the citations that come at the end of sentences or the references that you're using. So, these are the references, very basic. There are many softwares that are available to do all this. I made a chart to compare, but then most important things is this. So, 2 of them are free. So, we are going to use these 2 free softwares. And most of the time, what I use personally is Mendeley. So Mendeley is free and it is being around for more than a decade. So I've been using it very often. It has 4 tools. So web-based, web importer, desktop client, as well as a plugin for Microsoft Word. So it's very, very easy to use. This is the homepage of Mendeley, very impressive. So I'll show you a video demo on how to go about this. So this is the homepage. You can access your library. So I'll show you how to create a library on Mendeley. You have to sign in. So this is owned by Elsevier company, but it is a cross-platform app. So it doesn't only take Elsevier articles. So now I have signed in inside. And when I click on my library, it shows all the articles that I have gone through and various projects that I have done. So these are all my research projects that are happening. Once you are logged in, you get this option of downloading the reference manager. Once you download it for Windows or Mac, works both, your entire library from your website is also integrated in your desktop. So everything is there. Even my publications are there. You can add new PDF by using this tool. Once you add a new PDF or you can add a new citation manually, it shows in your library on Mendeley. So for example, for BSS citation, I have done some literature review. I can add that too here in Mendeley software. Okay, there are a few more tools. For example, this one. Yeah, so I can install this site, Mendeley site. This is a Word file, plugin for Microsoft Word. You have to log into your Microsoft account to use this. So this is one of my papers. So I'm writing this. I want to insert. Once I have the plugin, it will show on the top of Word file. And once I click on it, it will bring all my library articles there. Okay, so it will start showing my library articles that I have uploaded and various projects also. So once I click on anywhere in the text in the Word file, I can actually add my references directly here. So for example, at the end of this paragraph, if I want to add a reference, I'll just click there and add citation. So it numbers the citation also. I can even change the format and make it whatever format I want. For example, I want a Vancouver format. So it will change the format easily. So this is important when you submitted an article, you get a rejection, you're submitting to another journal, and the entire format is different. So you can easily do it, you can easily reinsert, number, it will automatically number your citations. And at the end of the point, it will add the bibliography to it. So, okay. So it will insert the bibliography at the end of wherever your cursor is. So entire bibliography in the proper format gets inserted automatically. So that's, Zotero is again a free thing, and it is works on same principle as Mendeley. I think I find Mendeley as more user-friendly. Again, this is Mendeley search page. So once you're logged in, you can do a search in Mendeley. So I'm searching for articles on AI in orthopedics, and it immediately gives me articles. And if I add an author name, for example, I add my name, and it gives me 2 articles on orthopedic, AI in orthopedics that I've done. So it's so easy to do that. Since I went to AI, let's see how AI is improving literature review as well as referencing. So EndNote is a paid software, around $300 per month. Zotero, they are both liaising in some way to AI. But again, Zotero is still in very basic, while EndNote is advanced. There are 2 websites which are very important for us for literature review, chatpdf.com as well as Ask Your PDF. I'll show you a demo of Chat PDF. Here you can upload any PDF to the website. So for example, here I uploaded one, and I can ask question to the PDF. For example, I have asked learning points from this paper, and it gives me a proper learning point from that paper. So you can individually ask questions to that. So that's about these 2 things. The next thing is about Ortho AI that we have been developing since a year now. It is, I mean, we claim it to be the world's first orthopedic AI, and it's made in India. And let's see what it does. It's again a web-based client. You can go to ortho.ai on Google and see it. You can sign in using Google. And it is free to use. You can start asking your queries directly. Even literature review related queries you can ask. So this is how it works. So I've asked about complications of a surgery, and it enumerates the entire thing. This is the special thing that we are adding to Ortho AI. It is called Ortho Reviewers. It aids in literature review. Actually, I started working on this just 3 weeks back when Ayyappan confirmed the topic with me. So I think Ayyappan and BSS can take some credit for development of this. It's a very good tool. I'll show you how it works. For example, here I mentioned summarize recent studies on knee surgery. And it immediately gives me recent articles and summarizes them. Okay, but I don't want 2. I said I want 10 more recent articles. So it goes and search Google as well as PubMed for recent articles and gives me 10 recent articles properly. Okay, along with the PubMed link that it is getting. So it doesn't stop there. Next, what I do is I ask it to write a narrative review summarizing important learning points of these 10 articles. So this is what I'm writing, write a narrative review, include the citations. And within seconds, it creates a narrative review of all those 10 articles and gives me a proper narrative review along with title, with introduction, and with citations. So that is what we'll be integrating within 2 or 3 weeks with Ortho AI, so you can do the entire reviewing on Ortho AI also. So it's an evolving system, and we are exploring and researching. Like I said, it's made in India. And we are taking baby steps, but surely we are going to be there. Future will be a co-pilot. We will be there physically, as well as the digital universe, it will be a physical universe. So in future, we are going to do it together. You can join our WhatsApp group scanning the code. Okay, thanks.
Thanks, Ashok. Ashok, just one question. Like, suppose we have people who want to write a lot of papers now.
Yeah.
The question is like, so most of us, okay, we find it difficult to pay a lot of money.
Yes.
$300, $500. So which is the best citation manager? And
Mendeley. Free.
Yes.
Mendeley is downright best. It is free.
Okay. And no. Any questions, Prince?
Sir, is there any commonly used softwares to manage the statistical errors or something like that while writing a paper? Your data might not be like.
There are a lot of websites that will give you individually. So utilizing that, I think best is to utilize a statistician service. They are not very costly, really. They are not really very costly.
So the meta-analysis and systemic reviews can be done with your the new.
No, not right now, but very soon. Maybe I'm giving it a year's benchmark. So within a year, it could extract the exact data from each paper and create a meta-analysis for you. Yeah.
Thank you for this presentation. It's amazing.
Thank you.
I don't know where are the limits. There is no limits.
There is no limit.
If we just practical question, if we compare Menley and EndNote, except the price, do you see a big difference or?
EndNote is much smoother. It's slightly user unfriendly, so it has a learning curve. But once you learn it, it gives you much better in-depth analysis of papers than Mendeley or Zotero gave you. So that's true. That's why they charge $235 per month.
But no, you can buy one shot. No,
No,
okay.
it's not one shot. It's a regular renewed payment.
Ah, you mean by year, yeah?
Yeah.
Same.
Thank you.
Brilliant. Thank you, Ashok sir. Next, we'll be having a video by Dr. Nikhil Verma, that is balloon rotator cuff.
So it's a balloon is a new technique which is going to be launched in India, and it is going to be a very important tool, especially with difficult cuff, partial repairs and all that. So here Dr. Nikhil Verma is trying to get him online, but the video is going to play now. Hopefully he'll join us to take questions.
My name is Dr. Nikhil Verma, Director of the Sports Medicine and Shoulder Service at Rush University Medical Center and Midwest Orthopedics at Rush in Chicago, Illinois. In this video, I'd like to present to you our rationale, technique, and indications for use of the subacromial balloon spacer in the management of massive rotator cuff tears in our patient population.
The original rationale behind the development of the balloon was to protect a repaired rotator cuff by reducing subacromial pressure and friction on the healing tissues. In the setting of irreparable rotator cuff tears, it is implemented in a different manner. For this injury pattern, the balloon is designed to act as a temporary spacer between the humeral head and acromion in order to restore a more anatomic relationship between the glenoid, humerus, and acromion. This serves two major functions. First, it improves painful symptoms by reducing acromiohumeral contact pressures and minimizing friction between these bony surfaces. Second, the balloon improves function at the shoulder joint. This occurs because the balloon depresses the humeral head to a more central location on the glenoid. This restores the coupling forces of the subscapularis and teres minor, and also amplifies the deltoid load via improvement of the deltoid lever arm. This function is analogous to the effect that is seen on the deltoid after a reverse total shoulder arthroplasty in the setting of rotator cuff arthropathy. Additionally, by relieving pain, patients are more adequately able to rehabilitate the shoulder.
Nikhil sir, this is Ayyappan. We just joined now. Thank you for coming. I think it is very early in the morning for you. Thank you for joining us at BSS Bangalore Shoulder Summit. And today we had a fantastic program, and this is the last leg and the last lecture. So we have started playing your video. Hopefully you can see it.
Okay.
Yes.
Yep, great.
Yeah, we can.
By durable pain and functional improvement even after balloon resorption. A 2019 study demonstrated the biomechanical efficacy of the subacromial balloon spacer for irreparable supraspinatus tears. The authors noted that the balloon spacer implant immediately increased the acromiohumeral interval, which would correspond to decreased subacromial friction and resulting pain. Additionally, the implant restored glenohumeral contact pressures over a dynamic range of shoulder abduction. This suggests that the balloon can immediately restore the anatomic relationship and articulation between the humeral head and glenoid upon deployment. Finally, by providing a more central position of the humeral head relative to the glenoid, the balloon spacer is able to elongate the deltoid lever arm and maximize contraction capacity of the deltoid muscle. These findings were echoed in two separate biomechanical studies examining the technique. A 2018 study found significantly decreased mean and peak subacromial pressures during flexion and abduction after insertion of the subacromial balloon spacer. A 2019 study found no significant difference between the subacromial balloon spacer, superior capsular reconstruction, and an intact rotator cuff for abduction force and abduction range of motion.